In our today's video, we are going to look at what we need to know about pneumonia is a definition of pneumonia, what causes pneumonia, how it happens, clinical presentation, different types of pneumonia. We need also to know diagnostic workups that are being done in order to diagnose pneumonia. So let's begin with a definition of pneumonia. Pneumonia is just an infection or inflammation of lung tissue. And we have two major causes of infection or inflammation of lung tissue. One being inhalation, when you inhale any pathogen or anything that will cause damage or infection to your liver. Another thing is aspiration. Aspiration is when you when food or any substance enter accidentally to your lungs. That is what we call aspiration. And what aspiration initiates is coughing. So you will cough out that particle that tries to enter in your lung. So we have some people who have chronic diseases that may affect coughing reflex. We have what we call stroke. When people who have stroke have weakness in muscles around the neck. Also, we have people who are adult and have dementia. We have Parkinson's disease. People with gastroesophageal reflex disease. We have what we call multiple sclerosis. We have other conditions that may affect these muscles may lead to these people aspirating any particle that may end up destroying uh, your lungs. So another thing you need to know is we have another cause that's not so common, but common with people who uses IV drugs, and this is what we call staph aureus. Staph aureus is not a major cause, but common with people who are using IV drugs. So let's try to see on how this happens. So how does inflammation or infection causes a problem in your lungs? So this lung, how does this happen? So let's try to connect it. So the first thing you need to know about your lung is that your lung have what we call a pseudostratified ciliated columnar epithelium that hold the ciliaries around the trachea. So these ciliaries will try to filter or humidify the air entering it. So if the particles are larger than the air you are breathing, it will be draft and then it will be coughed out before entering into your lung. So this one mechanism that your lung will try to bend or counterattack these particles entering your lungs. Another thing is immunoglobulin. Immunoglobulin is IgA. Immunoglobulin IgA, they are present in the mucosal region. This mucosal region is full of IgA. So these IgA are they are agents that will try to fight bacteria, and they will try to fight any viral infection. They will try to fight any bacteria that tries to enter to your lungs. That's another mechanism. Another thing is macrophages. Macrophages are present here. We have macrophages are present here in the alveoli region, and these are called alveolar macrophages because we have different types of macrophages. Like in liver, we have the guva liver macrophages. In spleen, we have splenic macrophages. In the central CNS, we have microalgia macrophages. But now this world alveolar macrophages. So macrophages are agents that when bacteria sets inside your lung, they counterattack. So if it happens that these pseudostratified ciliated columna are destroyed, let's take for example your columnar stratified ciliated region has been destroyed by either smoke or alcohol. So what will happen is there will be entry of bacteria. So when it enters inside here, it will enter to your either bronchioles or do alveoli. So when it reaches the alveoli region, there will be information to macrophages that there is an enemy. So what happens when macrophages are being informed that there is an enemy. Macrophages are phagocytic agents, so they phagocytize, they engulf. They try to engulf, and as they try to engulf, they also secrete some chemicals that are chemotactic. So chemotactic agents are chemicals that send information to your vascular region, that's capillaries, that there is infection and more of white blood cells are being needed inside the alveoli region. So they secrete also uh, leukotriene. Leukotriene will enter up to the vascular region, that's capillaries. And as they reach capillaries, they inform that white blood cells are being needed, and some of these leukotriene will bind into the endothelial system. And as they bind to the endothelial system, they cause more permeability. White blood cells enter into your alveoli region, causing more permeability. So there will be more permeability, allowing more fluids to enter up to your alveoli. So all these all these agents will cause inflammation also as they enter into the alveoli region, and also more fluid will more of particles causing your alveoli region to malfunction, and these will cause or entire or the entire lung to malfunction. So when macrophages decrease leukotriene will enter into a vascular region. Your vascular region will be informed that there is an enemy. It will enter some of the leukotriene, for example, C4 and D4 will bind to your vascular region, increase permeability. When there is increase in permeability, there will be more spaces, allowing more fluids to enter, allow more red blood cells to enter into your alveoli region. There will be inflammation because of secretion of cytokinins. We have secretion of tumor factors, secretion of certain protein metabolites, secretion of arachnoid metabolites. So all these agents will cause inflammation in your alveoli. And when there is inflammation, we have seen there is more fluids entering there, causing congestion. So another thing we need to know is about the staging of pneumonia. So the first one is congestion, red hepatization, and then what we call gray hepatization and sensation. So let's move on. So we have seen pseudostratified ciliated columnar epithelium is the one that allow filtration or humidification because of presence of cilia. But when these are being destroyed, they will allow particles to enter to your lung. So you should know also of cough reflex when there is any particles inside your cilia. So that's another thing. We have seen about immunoglobulin in your membranal region of your lungs. So this one is a defense mechanism also against bacteria, against viral, against any infection. So we have seen about macrophages. These are the VIX. We call it VIX because we have different macrophages. Like for example, we have said we have what we call Kuba, liver macrophages. We have also splenic macrophages. We have microalgia macrophages in your central nervous system. So those are the different types of macrophages, but actually we are under lung, we are actually focusing on alveolar macrophages, and we have said that's phagocytic or they engulf, and also they produce some lysosomes, they produce some oxygen metabolite, they produce some antimicrobial beta peptides that help in elimination of certain macrophages. So imagine bacteria have set in your lung. Your macrophages will be stimulated to produce all these agents, and even producing cytokinins such as tumor necrosis factor, chemokines. We have arachnoid metabolites. So when all these particles happen, when all these production happen, they cause inflammation. So another thing we have said about the reflex action, when anything has been trapped under your cilia, there will be stimulation of vagus nerve. Vagus nerve will send information to medulla that we need to cough out something that has been drafted by the cilia. So another thing you need to know is we have certain substance or certain drugs that may inhibit cough reflex, and these are alcohol, opioid drugs. People who are on opioids will have inhibition of cough reflex and are prone to aspiration pneumonia. Another thing is anti-cough drugs also. Those people who are anti-cough will have inhibition of cough reflex. So we have said earlier that macrophages and macrophages can be also destroyed by alcohol or smoke. Same to pseudostratified epithelium. Uh, Pseudostratified columnar epithelium can also be destroyed by smoke or alcohol. So we have said when bacteria set in, they will produce some endotoxins that will start damaging the inner tissue of your lung, and the lung will stimulate the uh, the um the lung will stimulate antagonizing substance like leukotriene. We have seen macrophages stimulating leukotrienes. Leukotriene will be sent to blood vessels. Blood vessel will send more of red white blood cells. So this movement of leukotriene to the white blood to your blood vessel is called chemotactication. So because it macrophages possess certain network or channel that when there is information, leukotriene will be sent immediately to blood vessel to inform that we have an attack, or we have a problem inside the alveoli and we need more white blood cells. White blood cells will cause more permeability, and also remember this leukotriene will attach to endothelial system of white of this blood blood vessels, and when they attach to these blood vessels, it will cause inflammation, and when it causes inflammation, there is edema, allowing more fluids to enter into your alveoli region. So when there is edema, uh, there will be edema, there will be more fluids entering to your region. Another thing you need to remember is when there is tissue damage, there will be stimulation of the mast cells that cause inflammation when they produce histamine. So when histamine are being produced, there is also increase in permeability, which means there is a lot of destruction on blood vessels, and this I think it's a kind of autoimmune also, because the body is like fighting itself also, because when you increase more fluids entering to your alveoli, it means there is more of congestion. So we need to know the stages of pneumonia. The first one is simple because congestion. When these all these happen, increase in permeability of your vascular region, there is more fluid entering. Edema goes by, leukotriene binding your endothelial region, allowing more fluids to enter in your to your alveoli. So it will increase congestion because there is also inflammation there. So the first thing is congestion. Your alveoli become congested because there is a fight. It's like a battleground. It's like a war place. So there is congestion. There is many things in your alveoli due to damages taking place. After this, if this vascular region are being damaged, seriously, it will cause more permeability leading to white red blood cells to enter into your alveoli region. So what you need to know is congestion tend to happen between day 1 and 2. So after day 1 to 2, we have what we call red hepatization. Red hepatization is because you remember the signs of inflammation. One is reddening, red color. We have pain. So because there is inflammation taking place in your alveoli, there is a red color. Because of red blood cells going there, there is red color being given to your alveoli because of more red blood cells. This also remember there is inflammation. So your alveoli will start to turn to become red. That's why we call as day 2 red hepatization, and this is because of damage, more extreme damage of your vascular region, and then it will allow more fluids entering to your alveoli, causing congestion there. So when there is congestion, there is red blood cells there. Red blood cells gives the red color, and that's why day 2 is called red hepatization, as happened to be day 2 to day 4. So what happens is when red blood cells accumulate there, it stands to consolidate. So that's why in lobar pneumonia, in some lobar pneumonia, there is consolidation. It's because of accumulation of red blood cells, because of more damage of vascular region, leading to more permeability, more fluids, more particles entering, or more substance entering to your alveoli, causing consolidation. Stage 3 is what we call gray hepatization, because the red blood cells will start to shrink now because they lack oxygen. They will start to shrink. So when they are shrink, they are dying and they give the gray color. That's why we call gray hepatization, and it happened to be day 4 to day 5. And then resolution. This is when all particles in the alveoli started to be broken down and after breaking. So and this happened that coughing will be a prominent symptom now. Prominent where people will be coughing out sputum, which is productive, which means there is resolution. There is you are to counterattack. It's trying to save. There is dying of red blood cells. There is dying of these particles. They are being coughed out, and that's a good show of a symptom that's sputum production is because of resolution. It's happened to be day 9 to day 8 to day 9, or after a setting in of bacteria or viral or fungal or anything that may cause pneumonia. So let's proceed. Also, let's look at the causes. So causes is that we have 75 to 80% are being caused by bacteria. And what are these different types of bacteria that causes pneumonia? We have what we call streptococcus, which is streptococcus bacteria, which is gram-positive, non-motile, non-sporing, grows in Jane. So what you need to know is Staph aureus grows in clusters, while Streptococcus grows in Jane. So that's a good differentiation. When you do a microscopic examination, you will find that the strep grows in Jane. They are Jane-like, while Staph grows in clusters. So they contribute to around 65% of community acquired, what we call CAF. So community acquired pneumonia, 65% is being caused by Streptococcus pneumonia. Another cause is what we call H influenza or Amovilus influenza, which is a gram-negative, and it's a second most cause of community acquired pneumonia, and it follows streptococcus, and it's common with people with underlying condition like asthma, cystic fibrosis, stroke, or any other chronic infection. So H influenza is common with people with infection, chronic infection like cystic fibrosis, asthma, or any other chronic disease. We have what we call mycoplasma pneumonia. So this is a gram-negative bacteria, and it's a special one because it does not, it's not a gram-negative or gram-positive, because it does not have a cell wall, and also it's common in young ones. So this one is a special one because it doesn't have, it's not gram-negative nor gram-positive, because it does not have a cell wall, and it's common in young ones. So this type of bacteria is common in young one, and it's a type of pneumonia that produce that it produces signs that can help you to diagnose. They produce what we call bullous lesion. So bullous lesions are lesions like some people will present tell you that they have rashes that are grown to become valvular, and they are common in the ear region or tight region. So this bullous lesion can also be seen in meningitis. So people with mycoplasma pneumonia can possess bullous lesion, and when if they have bullous lesion, you will suspect that they may have uh, mycoplasma pneumonia. Let's take for example a patient comes in or to your hospital or to your clinic or to anywhere and tells you that they have lesions that are growing, and they have also possess the signs of pneumonia without underlying condition like meningitis. So you will expect to be a pneumonia. So what will be this type of pneumonia? Mycoplasma pneumonia. So that's another cause. Another cause is Legionella. Legionella is gram-negative, and it's common people working in cold region. So it's also contaminated. It's also passed through contaminated water and patient will present with vomiting or signs of hyponatremia. Low hyponatremia is signs of low sodium. So that's another cause, Legionella. Another one is Staphylococcus aureus. So we have said the good way to differentiate between Streptococcus and Staphylococcus aureus is that this one will appear in cluster form, while that one will appear in chain form. So people with this type of bacteria will this is a worst bacteria because it can lead to what we call medicinal drug or multiple drug resistance. Staph aureus is among the causative agents of multiple drug resistance, and it's common in post viral infection or people with immunocompressed system or elderly. So it's common with people with HIV and AIDS or any other chronic disease and people who are elderly. Another cause is Klebsiella. Klebsiella is a gram negative and common in patients who have a high susceptibility of aspiration. People who have aspiration, people who have stroke, people who have stroke, people who have multiple sclerosis, people who have anything that may cause or in inhalation are prone to this type of bacteria called um, are prone to this type of bacteria called Klebsiella. Another one is Pseudomonas aeruginosa. It's a gram-negative, non-aerobic spore forming, and it's common in immunocompetent or immunosuppressed patients, like people who have HIV, people who have cystic fibrosis are common to this type of Pseudomonas aeruginosa. Another thing we need to know is other causes, which include viral causes. So the major cause was bacteria. The second one is viral causes. Viral causes includes respiratory syncytial virus, which is common in children. We have influenza. That's influenza. We have cytomegalovirus, common in immunosuppressed or patients who have organ transplant. We have what we call varicella zoster. So these are the different types of viruses that may cause pneumonia. Let's continue. Fungal causes include we have some fungal causes, and it includes people who are immuno suppressed or immunocompromised people. Like pneumocystic jirovecii type of pneumonia is common in people who have HIV and AIDS. So fungal causes are more common in people who have who are immunocompressed. We have another type of fungus called is plasmosis capsulatum. We have what we call coccidiosis, common in desert soil. So it's common in desert soil. So these are the different types of causative agents of um, pneumonia. We have seen about streptococcus being the first one and contribute 65% of community acquired pneumonia. We have seen about legionellas. We have seen about mycoplasmas bacteria. We have seen about Klebsiella. We have seen about viral causes, influenza, cytomegaloviruses, varicella zoster. You need to remember all those. We have our fungal causes, and it's common in people who are immunocompressed. Let's proceed. So, clinical settings. Let's look at community acquired pneumonia. Community acquired pneumonia is pneumonia acquired at home or at hospital within 48 hours, but not more than that. If somebody comes to an hospital or are being admitted at hospital within 48 hours, they develop pneumonia. It means they came from home with pneumonia causative agents and they did not acquire within the hospital. So it falls under the category of community acquired pneumonia. And the most causative agent is influenza, chlamydia, streptococcus, legionella, mycoplasma, Pseudarella, and Pseudarellas are common in people with Gowon's disease. Another, let's look at hospital acquired pneumonia. Uh, People who have hospital acquired pneumonia should have stayed more than 2 days in hospital after admission. And these people have the worst bacteria that are resistant to drugs, and the most causative agent is Klebsiella. We have Staph aureus, we have Pseudomonas aeruginosa, we have Heterobacteria, we have Serratia. So those are the causative agent. Remember, in our community acquired, we didn't have Pseudomonas, we didn't have Staph aureus, we didn't have Klebsiella, and we didn't have Serratia. So you should have capability to differentiate the most causative agent of community acquired pneumonia and the most causative agent of hospital acquired pneumonia. Another type of pneumonia is what we call ventilator acquired pneumonia, and it's common in people who have been ventilated for more than 48 hours. Another type is what we call LD care associated pneumonia, and this type of pneumonia is common in people who receive home-based care. For example, people who have cancers, people who are being nursed at home, people who have chronic dialysis can have this type of pneumonia called LD care associated pneumonia, because these people need LD care providers around them at keeping time, most of the time spent with elder care providers. That's why it's called elder care associated pneumonia. So let's proceed. Signs and symptoms of pneumonia. Typical signs and symptoms of pneumonia include tachycardia. Tachycardia include another thing is we have tachycardia, increase in respiratory rate. We have said when your heart become congested, you will have shortness in breath, which means they will increase in respiratory rate. And also tachycardia is increase in heart rate. So your heart rate will increase because of that shortness of breath affecting your heart. Another thing is fever. So as you understand, macrophages, when they were fighting this infection, they initiate fever as another depending mechanism. Also another term is cough, which is mucovirulent, and we have seen in staging of pneumonia that the last stage was resolution, and resolution is when everything was being broken down and everything is trying to get being resolved. There was trying to cough all substance that was being um, received by alveolar because of increase in permeability of the vascular region. So we said earlier that when there was increase in permeability of the vascular region, there was most of substance leaking to your alveoli. So when they were being broken down at resolution stage, after around day 8 to day 9 or after 1 week, GOV was one thing that will be used to do uh, keep or to do away with these particles which was being broken down when your lungs was starting to undergo resolution. Another thing is shortness of breath. We say due to the congestion there was shortness of breath. So those are the typical signs of pneumonia. So let's try to see typical signs. We have nausea, fatigue, grade 1 fever, myalgia, uh, dry cough. So we say atypical because it does not tell you that these signs can be pneumonia, but it can present with other condition. Other condition can present with these signs, and that is why we call atypical. Diagnostic procedure, we have physical examination, and we start with inspection, where you will inspect all parts of the chest region. So under your inspection, you will see there is increase in respiratory rate. Respiratory will increase because there is shortness of breath. Your chest is being congested. There will be need of use of accessory muscles like glycol muscle may be needed to use. So you should inspect the use of accessory muscles around the neck region, so that you can say under my infection there was a presence of use of accessory muscles. Another thing is intercostal retraction. Another thing is pleuritic chest pain. Patient will tell you, you will notice pleuritic chest pain because we see under our diagram that we have a pleural fluids around your chest. So when your chest become congest, it will mean this fluid will be pressed, and there will be friction against the walls, causing what we call pleuritic chest pain, and it causes lung to enlarge because of congestion and rubbing to the wall. So we have seen your lung will be rubbing to the tissue, causing friction, causing what we call pleuritic chest pain. Another thing is when you palpate, you will notice of what we call respiratory expansion. This means a unilateral decrease in one side of chest, and is common in lobar pneumonia. And what you need to do on this is holding both arms around the spinal cord at around the lumbar region. So you hold your two arms and you try to encircle, and then your patient breathe in and out. You will notice that there will be no unilateral movement. One side will be retracted while one side will be moving symmetrical. There will be no symmetrical movement of your hand, because one side will be moving up while the other one will be moving slowly. So you will notice the other side is like it's heavy while the other side is like is light. So that's what we call respiratory expansion, and you just need to hold both arms at around lumbar 5 or lumbar 4, and you tell your patient to breathe in and out as you try to encircle it with your both arms together, all at around number 5 or number 4. So when the patient breathes in and out, you will notice that one hand may move up while the other one will move slowly. So you will not have a symmetrical way of lung movement. So that is what we call retractory expansion. So let's proceed. Percussion. When you percuss, you are looking for dullness. So the only thing you will be looking for is dullness. You will be looking for any sign of dullness that will show there is consolidation. Another thing is auscultation. So auscultation is listening to the sounds or heart sounds, or but here we'll be looking over sounds on the lung. So what you will be looking at is pharyngeal breath sound, or crackle, or what we call relay. These are the coarse or fine sounds. Coarse sound are the longer, it takes longer time, while fine sounds take a shorter time. So those are the things you will be looking. Another thing is transmitted focal sounds. If there is any other sound as like transmitted, like bronchophonic sounds, echophonic sounds, or whispered vector Rolokai. So those are the things you will be looking, and this we call transmitted focal sound. Why transmitted focal sounds? Because we see earlier that there was fluid under your alveoli because of increased permeability of blood vessels. So fluids act as a media of transmission. So that's why we call transmitted vocal sound. So for bronchophonic is letting a patient say a certain praise like 66, 99, 77. So if it become more clear, then it means there is a media of transmission. It should not become so clear, because air is not not air, but there will be no fluid that actually act as a media of transmission. So if a patient says 66 and you hear from your with your stethoscope that is very clear, then it means there is a media of transmission. That we call bronchophonic. For echophonic, you let the patient say e sound. We should not be. We should for a patient with pneumonia should be clear. But when you hear like for a patient with pneumonia, it should not be clear. It should be like uh, uh, uh. The patient was to say e, but you are hearing uh, uh. So it's like there is something obstructing that sound. It's used the signs of consolidation and increase an increase of low density tissues in your lung. So that's echophoning. You let the patient say ee, but for patient with pneumonia, the sound will be because of obstruction by consolidation of some tissue or presence of low tissue density. Another one is whispered pectoralica. So whispered pectoralica is when you let the patient whisper 1, 2, 3, 1, 2, 3, 1, 2, 3. So when you hear, if this will be clear, it will mean there is a media of transmission and it's a sign of pneumonia. So those are common things that you may need to do when you are diagnosing a patient with pneumonia. But this should not give you an accurate diagnosis that this is pneumonia. You will need to do other things like just X-ray. And in lobar pneumonia, you will have features of consolidation. In bronchopneumonia, there will be white pigment, look like a string, or round pigment, and it's bilateral. So these pigments, when it's bronchopneumonia, these pigments that are like strings. They are like wires. They are thin and or round pigment or round pigment, and it's bilateral. Those are for bronchial pneumonia. For interstitial pneumonia, they are same as bronchopneumonia, but remember, for interstitial pneumonia, the pigment will be common in perialar region. Perialar is where arteries and airways enters and leave the lungs. Those end region by arteries, or those end region by airways. So the pigments will be on those regions, not in every region of your lung. So that is why we call perialar region the places where your airways enters, or uh, your arteries enters to your lung and leaves. Those are the biliary region. So it's the same as bronchopneumonia, but only common in regions where arteries and airways leaves or enters to your lung. So those are the key things you need to know. For lobar pneumonia, you have consolidation. For bronchopneumonia, you have white pigment which look like strings or round pigment, and is bilateral. I think one time we need to have a video of this so that we can see it clearly. And another thing is interstitial pneumonia. You have these strings entering at the region where the blood vessels, that's artery or airways enter to your lung. So that's the thing you need to know. Another thing you can do is sputum cytology. So another thing you need to do is sputum cytology, and this is you can have for a gram staining to know which bacteria is there. So for culture strep pneumonia, it's a rust and it has blood stain for strep pneumonia. And for Klebsiella, which we have seen is common in people who can aspirate, is garan jelly-like. So it's like garan jelly-like. For aerobies, we have fully smell sputum, because aerobies it means they use oxygen. Anaerobies it will means it's fully cement, because it will mean those agents are decaying. Another thing is green sputum, and it's common in pseudomonia, hemophilus influenza. So another thing you can do is blood work to see if there is increase in white blood cells, to see if there is increase in um, ESR due to inflammation, or if there is raw red blood cells, because we have seen when there is extreme damage in your vascular region, more of red blood cells will enter to your alveolar, and even the red blood cells will enter, and then they just start to die there. So those are the things you need to do in order to diagnose pneumonia. So I think in our next video we'll be discussing on medication or management of pneumonia, and we need to go slowly by slowly from community acquired, hospital acquired, to any other type of pneumonia. So I think you will enjoy this video, and I ask that you may subscribe for our base so that we can continue educating each other.